Welcome, everybody. We're here today to talk about the topic of benzodiazepines. And the topic today is risks of benzodiazepine medicines in older adults, mood, sleep, memory, and motor problems. And our guest speaker today is Mr. Jaden Brandt. He's sitting right here in front of me. He is a member of our board, and he has graciously agreed to do this talk for us today. So thank you very much. We are filming it. We wanted to share this with our cohorts in the Brandon region, so we're going to share this with them after. So I just want to give a brief bio about Mr. Jaden Brandt. I'm not going to read all of your accolades because I can't even pronounce half of them, but you are a practicing home care pharmacist in Winnipeg, Manitoba, with a special interest in geriatrics, polypharmacy, which is the use of multiple medicines, and psychopharmacology, medicines for mental health. His most focused area of research expertise is on benzodiazepines and Z drugs, like zolpidem. I apologize if I pronounced that wrong. Having published multiple academic papers on the patterns of use and harms associated with these medications. He is a board member for both the Alliance for Benzodiazepine Best Practices, a not-for-profit patient advocacy and charitable research organization located in Oregon, USA, and the Mood Disorders Association in Manitoba. So without further ado, I'm going to hand this over to you.
Thank you very much, Pam.
Thank you.
It's a privilege to be here today to speak about one of my passions in terms of pharmacy practice and improving patient care in terms of mental health. So we're going to delve into each of these topics individually, hopefully answer some of the questions people have in their minds, but then we'll also have a Q&A afterwards so that we can delve a little bit deeper based on what people are curious about. So thank you, Pam, for the brief introduction. Just to elaborate a little bit more, I've been a community pharmacist for 10 years. I started working in Thompson, Manitoba, which is where I'm from. Came back down to Winnipeg to do a master's degree, and that really got me interested in benzodiazepines. My thesis project was on benzodiazepine use in adults in Manitoba. Since then, I've gotten involved even further with teaching toxicology for pharmacy students, as well as conducting research projects and being a consultant for the Alliance for Benzodiazepine Best Practices in the U.S. So just any talk about benzodiazepines, especially for a lay audience, should begin with just a little bit of background about these drugs. You'll see in the top right-hand corner, that's just kind of the basic skeleton of what one of these drugs looks like in terms of a molecule, but it's not overly important. What is important is that they've been used since the 1960s, so over 50 years now, over 60 years for predominantly anxiety and insomnia more than anything in the outpatient population. They're also used off-label for muscle relaxation. They're used in the perioperative setting in surgeries and anesthesia to kind of help with relaxation and putting people into unconscious states. They're also used for alcohol withdrawal to kind of help manage issues such as tremors, delirium tremens, and reduce toxicity from the withdrawal itself. The Z drugs were introduced in the 1990s, and they were marketed for many years as being safer. However, that hasn't observationally been the case when we look at population studies, and this kind of common wisdom from the pharmaceutical industry has come into question a number of times as to whether they truly are safer. They are subject to persisting controversy over the known harms. Predominantly, both Z drugs and benzodiazepines are known to cause psychomotor impairment, and they're culprit medications for abuse and misuse. Oops. So this is a new Netflix documentary. It's very recent and is aired and focuses on one of the benzodiazepines with the most street cred, as well as kind of the most hated among doctors in terms of its utilization is Xanax. It has the worst kind of abuse potential, and in Manitoba, in terms of the standard of practice guidelines for benzodiazepines, it's often discouraged now. This is data on the use of benzodiazepines in the Manitoba population. This only goes up until 2016, as that was when this research was published by myself and colleagues. But you can see a very clear trend, and this is very consistent with international data all over the world in different countries, but we do know that the use is higher in older adults, predominantly for insomnia above anything. We know that as people get older, sleep quality declines, and we'll talk a little bit more about that. And then clearly, doses are higher in men than women. But it is concerning. You can see some upward trends and then a little bit of a dip. And they've been mostly stable, but there's still issues with overuse by far. In terms of benzodiazepines and mood disorders, benzodiazepines are not a treatment for mood disorders of any kind. They have been looked at as a treatment for anxious depression, but really this is in the setting of managing anxiety symptoms, which are often concomitant or happen alongside mood disorders, particularly depressive illness, but can also be used in bipolar disorder as well for anxiety and mania. But in terms of actually treating the underlying mood condition itself, whether it be mania or depression, they're certainly not recommended. They've also been associated, and there's increasing research on this, and it hasn't been proven by any means, but there is a clear association with suicidal ideation and self-harm impulses. So we think that perhaps benzodiazepines, especially when they're maybe taken with alcohol or in settings of disinhibition, people's behaviors can be more erratic, and despite that the benzodiazepine is meant to be sedating, it might be inhibiting a certain aspect of the personality that then leads to these kind of suicidal attempts or self-harm behaviors. Very rare, however, so it's not something that should prevent somebody from taking a benzodiazepine is fear of this, but for people that are acutely depressed and are already having these kind of behaviors, it is a concern. Especially when they're being taken in conjunction with other agents such as alcohol and opioids. In older adults in particular, it has also been known that they can cause a bit of this what we call paradoxical agitation. So this is mainly in the setting of dementia or underlying cognitive impairment problems. And this is very, very uncommon. It's more often observed in personal care home settings, but it's probably in a mechanism in the brain very similar to this suicidal impulses and ideation. It can really set somebody off and lead to almost aggressiveness, agitation, emotional outbursts. Unfortunately, in spite of how rare this is, sometimes the obvious clinical response on the part of prescribers and pharmacists is, well, their benzo dose isn't high enough, so let's just increase the dose, which is actually not the answer in that situation. In terms of benzodiazepines and memory concerns, this has been reported a lot more over the last decade in particular, and there's been a number of population-wide studies both in Europe and North America looking at its association with dementia and Alzheimer's. In terms of what we know, in terms of its effect on the brain, not just on domains such as memory, but we do know that benzodiazepines can have an effect on limiting a person's attention and focus, and that's clearly just because of the obvious sedative effect. But it can, with long-term use, seem to have a residual effect on different forms of memory, as well as general intelligence and visual spatial ability. So whether this is these kind of markers based on psychological testing is linked actually to whether an underlying pathology that's leading to dementia, that's very unclear. But based on numerous studies, it does seem to have some impact on people's mental state, whether they realize it or not. And is particularly common with long-term use. People also get used to the way they're feeling on the drug, and so they might not really realize how impaired they are until they can slowly over time taper off of it and get back to a baseline setting of feeling more normal again. As I had mentioned, the link with dementia and Alzheimer's disease is not yet definitive. Some studies suggest a link and others do not. On the whole, there may be a real small risk, so the association might be accurate, or there might be some causal mechanism whereby high doses of a long-acting drug taken for decades might actually increase risk of dementia, despite that this hasn't really been proven experimentally, or we haven't seen any problems with the brain tissues and things of that nature. The other problem is that in many instances, people that are experiencing dementia start to have mood changes and agitation, and that does lead to a person starting a benzodiazepine. The actual diagnosis of Alzheimer's might happen later, so it kind of turns into this chicken and egg problem. What came first, the benzo or the dementia diagnosis? So it's a very complicated area, but it isn't something that we should be fear-mongering about. But if it does offer motivation for a patient because of concerns about memory or dementia to try to come off of the drug, then I think that that's totally fair, and I encourage that as a routine. In terms of sleep concerns, benzodiazepines, and particularly Z drugs such as Zopiclone, are the main agents that are used for insomnia in primary care. Zopiclone in particular in the province of Manitoba has increased in terms of usage by threefold, so 300% increase from 2001 to 2016. I haven't looked at data since then, but I imagine the trend has stayed at least stable, if not possibly increased, but that's purely speculative. The drugs do work similarly on the brain. They are a little bit more selective for a certain part of the benzo receptor where benzodiazepines bind. I won't get into the complex pharmacology of it because I don't think that's important or useful for this audience. Sleep is often felt to be much better at first when patients start using these, and there's no doubt that they work very effectively, very rapidly, and acutely for insomnia, sleep disturbance, whether the insomnia is from secondary to a mood problem or grief or some kind of underlying trauma that's preventing somebody from getting a good night's sleep. They do work very well. Unfortunately, in terms of its actual perceived benefit is less than what we see in sleep studies. So based on sleep studies and actually measuring sleep time, people only sleep by an increase in the range of minutes, not hours. So people might get maybe 30 minutes more of sleep or 20 minutes more of sleep, or it might reduce their time to sleep onset by 15 minutes, so they're falling asleep faster. And they might feel more refreshed or that the drug is helping. But in terms of the actual objective measures, that isn't necessarily the case. So patients frequently report that the drug is helping more than it might actually be. And importantly, over the long term, these agents, they do appear to disrupt the sleep architecture. So we might have heard of different forms of sleep, such as non-REM or REM sleep, rapid eye movement sleep, so the type of deep sleep where people are dreaming. Benzodiazepines increase the time in the less restorative form of sleep, so non-REM. So people are more likely to have sleep, but it might be more lighter, groggier sleep, and less time in the more restorative, restful sleep with kind of dream content or feeling more refreshed, where their brain is getting the actual sleep nourishment that it needs. In terms of benzodiazepines and movement issues or motion concerns, benzodiazepines have long been linked to falls in the older adult population. As people get older, their muscle mass decreases, they might be less coordinated, have arthritis, various other physical ailments. And the benzodiazepine for especially frail older adults can absolutely increase the risk of a fall. It does this perhaps through relaxing the muscles, but we also know that with the effects on the mind and coordination, it can cause instability in people's posture. When they're walking, they might have less hand-eye coordination, things of that sort. And this can cause momentary lapses in judgment as people walk, and it has been linked to falls, and in worst cases leading to fractures. So we know that certain types of fractures, like hip fractures, increase the risk of death. So indirectly, benzodiazepines, when they do cause an incident like this, are linked to mortality or death. Also importantly is the risk for driving accidents. So benzodiazepines and related drugs are often detected in the blood serum of people that have been involved in fatal motor vehicle accidents. they have the potential to impair drivers. In fact, zopiclone has been used as a positive control, meaning that when they're studying the effects of other drugs on people's ability to drive, they use zopiclone because they know that zopiclone causes impairment. And it basically, the way that they measure it is based on kind of highway driving down a straight a lane of road. If people are very slowly drifting, the extent of drifting as they're on the medication. It does tend to be more common in the early hours of the morning, if after a dose of, say, something like zopiclone, which is at night, which coincides with the lingering effect of the drug from the night before. But certainly benzodiazepines that are taken multiple times a day for things like panic disorder or various anxiety-related conditions, the risk is going to be more probably commonly present. This is an interesting one. So whether benzodiazepines actually cause addiction. And this is controversial, but based on the overall kind of assessment of the data, when we look at drugs that do cause addiction, benzodiazepines are far less euphoric and in a way less reinforcing than street drugs like cocaine or methamphetamines or even opioids for that matter. So they not really, but they can rarely cause what we call a benzodiazepine use disorder, or which is kind of the vernacular now that has replaced addiction. So there have been cases, but it is far less common than with other drugs. The risk tends to be higher in people that are already have a drug use disorder. Most people do not become compulsive with its use, meaning that they're actively, if they don't have the benzodiazepine, they're doing whatever they can to seek it out and use higher and higher doses and abuse it. That being said, street benzodiazepines that have made it into the street drug supply on the West Coast, as well as perhaps eventually, and I hope not, coming into Manitoba's street drug supply, they might be of a very different nature than the medical grade benzodiazepines that have been used for decades. So it's yet to be determined to what extent their pharmacology might be slightly different or have higher risk for addiction. What we do know, however, is the issue of dependence among long-term users. Nearly all users with long enough daily use of a benzodiazepine, and dependence can happen in some people as early as a couple weeks, but more commonly after 4 weeks or more of continuous use. Most people, if not all people, will develop tolerance, meaning that the certain aspects of the drug effect are not nearly as potent as they were when they were first using it, and they might need higher doses. Or they can develop dependence, meaning that withdrawal symptoms will occur if the drug is stopped abruptly or even tapered in some instances. Withdrawal symptoms can still occur. So there's multiple ways, I'll just as a summary of some of those topics in terms of the progression to benzodiazepine-related harm. And I apologize for this acronym. This is from another presentation, but BZRA means benzodiazepine receptor agonist. So it's more of a shorthand that encompasses both benzodiazepines such as your Ativan, Valium, Xanax, and the Z drugs. So it's an acronym that includes both of those medication classes. So when we have a new benzodiazepine user or BZRA user, 6 to 15% of your average adult population, but increasingly up to 50% of older adults might eventually move on to chronic BZRA use. And chronic use is defined differently in the medical literature, so there isn't a consensus widespread definition, but most commonly within physicians' practices and medical practice, pharmacy practice, we think of it as greater than 4 to 12 weeks. In the observational population literature, the most common definition is greater than 6 months. But somewhere within that range is the percentage of people that go on to become chronic users. The chronic use it can certainly be linked to motor vehicle accidents and falls, but there's some research that actually suggests the early use is what is linked to motor vehicle accidents and falls, because people have not yet necessarily developed tolerance, or they've maybe underestimated the effect of the drug on their mind. So those first initial doses, if people aren't necessarily taking them seriously, they're more likely to have those accidents early on. There's also the issue of use disorder, as I had talked about, BZRA addiction. So that is a very low potential or percentage of people, perhaps 1 out of 50 of chronic users, or even less, that go on to become truly, and I'll use air quotes, addicted or have a benzodiazepine use disorder. However, you see, as I had mentioned, a much, much greater proportion of individuals with regular long-term use do become, have dependency, tolerance, or even impairment, whether it's noticeable to them or not. And then finally, the issue of overdose. Benzodiazepines are still a culprit for overdose, but they are actually very, very safe when we think of monodrug overdose. So when they're not combined with anything else, I certainly don't recommend it, and it is still dangerous, but it's very rarely been associated with death or fatalities from large ingestions of benzodiazepine. When they're combined with other drugs such as opioids, that risk for fatality does increase dramatically. So this is an emerging area that I want to talk about that is coming forward from fellow researchers in the United States, and it's called bind or benzodiazepine-induced neurological dysfunction. So what this, the way you can kind of just think of it is, are benzodiazepines causing kind of like a permanent brain dysfunction or brain injury in some way? Are they causing some form of brain damage? And this is not proven by any means. This is very early on, so there's no reason for people to become anxious or get concerned about it. Ironically, if they do, they might want to take a benzo, but that's not the solution for that type of anxiety about benzos. So it's a situation, seemingly based on patient experience, where some withdrawal symptoms never fully go away. And this is after people have been tapered off of the drug very carefully. They might have been off of the medication for 6 months, maybe even years, and there are some lingering symptoms of withdrawal. And if you go on and look at the Benzodiazepine Information Coalition or the Alliance for Benzodiazepine Best Practices, you'll find symptom lists of bind, and they're quite extensive. Even the early research out of the UK by pioneers like Dr. Heather Ashton, a very world-renowned psychiatrist in the benzodiazepine research space, she'd listed probably close to 100 symptoms or more of possible benzodiazepine withdrawal. Whether all of those symptoms are truly from the benzodiazepine or not is hard to say, and it's difficult to validate each and every single one of those symptoms. What we do know in terms of withdrawal is that the most common tend to be the opposite effect of the drug itself. So we'll see situations like increased anxiousness, agitation, maybe tremor, nausea, diarrhea, things that are maybe linked in the body to anxiety-like symptoms when the benzodiazepine is stopped. But there's also been more rare reports of things like tinnitus or ringing in the ears, or headaches and various other maybe visual issues, some more unusual kind of organ symptoms that you wouldn't typically expect from benzodiazepine withdrawal. So the bind issue or brain dysfunction or damage from benzodiazepines is still being actively researched. This is from a survey of some colleagues where they did a survey of over 1,200 bind sufferers, and based on these being the most common symptoms of long-term withdrawal. So the memory loss issue is similar to what was talked about earlier in the presentation, difficulty focusing. These bottom ones being very linked to the possibility of that residual neurological issue from benzodiazepines. And then some of these possibly being, it's hard to determine in all cases, but could be linked to the original disorder for which the benzodiazepine was used. So things like anxiety disorders coming back after the benzodiazepine is stopped. But most respondents experienced all of these 5 symptoms, and the median number of symptoms reported was 15 out of 23. So a pretty considerable amount, and this is based on survey study from users on a support forum. So these are regular people from all over the world who have been on benzodiazepines and have suffered some degree or significant degree of drug-related harm. Now, in terms of the patient experience and the what I would advocate is one of the best approaches for working with patients that are on these drugs, we want to kind of address and allay fears about stopping the medication and working effectively with patients in really a shared decision-making framework. We want to individualize tapering schedules and really empower people to make choices for themselves based on their life circumstances. We don't want to force a taper or take a drug away too quickly, unless, of course, it's causing significant or dramatic harm or there's something else that is going on. When I work with patients and I work towards establishing a tapering strategy, I like to kind of imagine it like a driver training type scenario. They're in the driver's seat, but I have access to that extra brake pedal, and I can kind of help guide them, tell them where to turn, when to slow down, how to adjust things. But I really want to emphasize that this is their medication in their body, and they know their body best. So we need to work with people to ensure that we don't precipitate or cause further harm by trying to get them off of what we deem as a harmful medication. People might be concerned about the effect of the benzodiazepine on the brain and the effect of stopping the benzodiazepine. We want to manage the expectations of withdrawal in terms of when withdrawal symptoms might emerge, when they might stabilize and start to go away. Have an action plan in case people do experience severe withdrawal, what we're going to do to correct that and make them feel more comfortable. Patients do better with a strong support system at home with either a spouse or children, family members that know that they're coming off of the drug and what they might anticipate or expect as the drug is being reduced. We might see changes in behavior or more maybe sleep difficulty temporarily, and that's even with very small dose reductions in some instances. Patients have often had negative experiences with different prescribers or providers, so it's important to find a prescriber who's comfortable with deprescribing or who is open to working with a pharmacist in addition to the patient to establish kind of the best path forward for them. Describing the exact plan and having the options in front of the person will help to build trust. And as I mentioned, this is all kind of based on this new paradigm of shared decision making where with situations based on medication that it has been long-standing that people often have a great sense of attachment to, whether actually in terms of feeling that the drug helps them or just fear of it being taken away. We really need to respect our patients' wishes and work effectively with them and not take them out of that process. In terms of the cornerstones or foundations for strategies for stopping a benzodiazepine, most guidelines will recommend gradual dose reduction, and that is the logical and most rational approach in nearly all situations with benzodiazepines or Z drugs for that matter. Some of the more recent and common deprescribing guidelines advocate for reductions of 10 to 25% every 2 to 4 weeks. Based on my experience and expertise, I think for many patients that does tend to be a little bit too quick. Patients can often withstand dose reductions early on that could be that high, but it's not uncommon that as the dose gets lower, you need to slow down and make sure the dose reductions go even lower as well. So when I work with patients, I try to fill this gap as both a medication expert, but also as a motivational coach or liaison for their physician or prescriber to guide them towards a safe dose reduction. And sometimes if that means stabilizing at a dose for a month or maybe many months, that's okay, but not losing sight of maybe the goal or reevaluating the goal, but also making sure that patients feel that they're moving in the right direction, they're feeling better at lower doses is important. As a general rule of thumb, and you won't necessarily find this anywhere in terms of the medical literature, but the idea of using maybe 1 month for every year that a person has been on a benzodiazepine consecutively might be a good strategy for people that are very sensitive to dose reductions or very reticent about coming off of their benzodiazepine. So if a person has been on a benzo for 20 years, trying to get them off of it in 3 months is pretty ambitious and will likely be very uncomfortable for them. So they might require something like a 20-month taper plan. And I've had patients that take well over a year to come off of their benzodiazepine, but they often do feel better after having done so. Another big part is cognitive behavioral therapy and other supportive non-drug treatments. So those are all the both psychological approaches and just healthy living approaches towards anxiety and managing a person's physical and health and mental health. So exercise, eating right, stress reduction techniques, things of that nature, meditation. That's pretty much all that I have. I do want to give acknowledgements to all of the my colleagues at the Alliance for Benzodiazepine Best Practices, who I work with, both psychiatrists and pharmacists, as well as the non-healthcare providers who have been or have relatives who have been affected by benzodiazepines in a negative way. And also a special acknowledgement to the Mood Disorders Association of Manitoba for giving me this platform so I can talk and educate about this issue, both and especially for Pam for organizing this and giving me the opportunity to speak today. I have references and resources that I'm happy to forward on to people after the presentation, both from my own research as well as others that are pretty substantial or important for delving in deeper into the details for people who are interested. And I'm more than happy to stick around for 20 minutes, half an hour for discussion or questions. So, thank you.
I had a question.
Yeah, for sure.
What are some of the common names of the common drug names
Yeah.
that benzos are in?
Sure.
'Cause
So
there was one I had been prescribed many years back. I didn't even know was in that class.
it was that okay.
Yeah.
So they're often used colloquially now, but it's very rare that people will be on brand name benzodiazepines because benzodiazepines have been around since the 1960s, but they still have a bit of a cultural presence in terms of how people refer to them. So some of the classical brand names that people might just say are Valium, Ativan, Halcyon, Klonopin. Xanax is probably one of the most common. That's one of the most prescribed in the U.S. Lorazepam is Ativan. So those are the brand names, but in terms of the chemical or the drug names, anything that kind of ends in your last name,
Yeah.
it might be a little bit of an indicator.
Stay with the Pams.
Yeah, not that Pam. You can always go and say hi to her. But yeah, Lorazepam, triazolam, diazepam, oxazepam, temazepam. So there's plenty of them. In terms of the most common ones that we see, it'll be clonazepam, lorazepam, diazepam, and probably temazepam. The other ones become less common as the years have went by. Yeah. Yes.
I'm wondering, so many older people suffer from insomnia.
Mm-hmm.
And I'm wondering, is there a physiological reason why we can't sleep? Or is it cultural or environmental or
Yeah.
lifestyle? Like, it just seems like every old person, I'm old, I'm 72, and my insomnia has been 30 years. Gets worse all the time.
Mm-hmm.
So when you go to the doctor, they say, no, don't take that Zopicon. But you can't sleep, you know.
Right.
Why is it so common in the elderly?
Absolutely. That's a really good question, and there is like a neurophysiologic explanation, but I'm not a sleep specialist, so I don't really know what changes in the brain in terms of maybe the circadian rhythm or the hormone changes. We know that sleep and the brain are hugely complex, but it is very well established that it's part of a natural aging process, but that also doesn't mean that older adults should settle and accept poor sleep, because there's still a way by which we can normalize healthy sleep behavior and also manage healthy sleep, even though maybe the expectations of getting sleep to the same level as it was, say, decades ago might be kind of too far out of reach. But if sleep is disrupting your day-to-day lifestyle, or it is impairing your ability to get tasks done, your focus, you're even worsening things like mood and anxiety issues, then it is significant enough that it should be taken seriously. And in some cases, I'm not completely against these medications. They do have a purpose, but it's how do we balance the risks of them appropriately. So there are a number of other medication options. Unfortunately, if you look at lists of appropriate medication use in the elderly or the older adult population, you'll find that it's not just benzodiazepines and Z drugs that are on those lists to avoid. So it really, you're tapping into something that's very true. It does become a bit of a catch-22. Now that I can't sleep, what can I do that isn't a pill? Or if I do have to take a pill, what is the best one for me to use? And for how long, and how do I manage it? So I think that always needs to be carefully individualized for the person. Yeah. Mm-hmm.
So I am quite a number of benzodiazepine groups. I'm in your group as well.
Okay.
And within these groups, and mind you, there are people all over the world.
Mm-hmm.
Some of them I've been in contact with.
Mm-hmm.
Private messaging and phoning for like 4 or 5 years.
Wow.
And a lot of them are, like, I know that I'm also in protracted elderly groups and
Okay.
the other groups, right? So we have a lot of, and I myself have been with multiple polydrugs
Mm-hmm.
because my doctor didn't realize that it was the benzodiazepine that was impacting me for a long, long time, right? But a lot of the individuals in the group are younger,
Mm-hmm.
right? They're 25, 30, 35. I'm talking to a fellow who's 40, right? And he's like 7 years off, and he's still got a lot of the symptoms that I still have,
Mm-hmm.
right?
Mm-hmm.
And I'm 6 years off now.
Mm-hmm.
And although I've improved an awful lot, like you wouldn't have known me before, right? It took me about 4 years, being cold turkeyed off everything, to sort of started being able to think. I couldn't read, I couldn't write, couldn't use a
Wow.
phone, nothing, right? Took me a long time to do that. And even now I'm losing my train of thought. That's the
No,
problem.
I mean, you presented yourself very clearly.
Yeah, so we seem to have a lot of younger people in the group too.
Mm-hmm.
Although I'm noticing that the older, and I'd say 50 and over, just my opinion, that's what I'm
Mhm.
noticing,
Mm-hmm.
seem to take a lot longer to recover from the damages done and from the dependency on the drugs, right?
Hmm.
The younger people, they're as severe,
Mm-hmm.
I think, but it seems to take them a shorter time to recover,
Mm.
right? See, for me now, I'm going into year 7, and I know I'm not well yet, right? I know I'm not well. I was very healthy before this happened. I didn't have any issues. I took it for sleep,
Yeah.
right?
Yeah.
So,
Well, thank you for sharing that.
I don't know.
My
Is there
condolences
a
that.
question in there? I'm not even sure.
Well, I think I can maybe infer a possible question or maybe a curious thought that you had, and it's maybe why are the younger people, why the difference maybe between the younger group and the older cohort, and why is it taking one group longer to recover than the other, or something of that sort?
We have a protracted group, which, well, you must be familiar with it. I'm
Mhm.
sure you're in the area, right? 18 months and longer to
Mhm.
recover, right? And as the time goes on, we have one from 3 to 8 years.
Mm.
Man, we have people in there that are still suffering. Now, I'm not saying they don't have other issues. I don't know, right? But some of them I've been talking to for a long time. And, there doesn't seem, medical doctors clear you. There's not medical
Yeah.
diagnosis. There's nothing wrong with you.
Yeah.
Like, I get acid squeezing in my body still. every night. It's so painful.
Mm.
I hope it'll stop. My doctor said it'll stop one day, right? But so as the group is older, you know, you reach 7, 8, 9, 10 years and you're still having symptoms.
Yeah, yeah. And I think that perhaps when we're dealing with symptoms that are that protracted, there perhaps maybe the best way forward for some people is a form of acceptance that this damage has happened to them. What do I do to move forward with my life in the best possible way? You know, still being there for others to maybe provide peer support or recognition and compassion and awareness and understanding, but ensuring that the symptoms don't hold you back from living your best life.
Yeah,
Right.
they call it radical acceptance, right? If you can reach that point and understand and try to build your life around, you know, I'm trying to rebuild my life around this different me now. Well, you know, I've left a lot of things behind. But I also am providing support to quite a number of people in their 30s
Yeah.
that really have the suicidal impulse, suicidal ideation, which I went through as well. You know, so I'm trying to somehow rebuild myself, right?
Right.
I don't quite know how to do that because it's changed my physical, I can feel it, right? I know it's changed my brain quite a bit and my body.
Well, it certainly sounds like you've come a long way, though.
Oh yeah, I had akathisia so bad. Oh my God, all I wanted to do was end my life, right? For years, 4 years. That's all. That was it. And I didn't have it before. I never had it before ever. But they pulled turkey off of it right at the recovery center. So
Yeah.
it really was a struggle.
Yeah. Well, I'm glad you're doing better. Comparatively.
Yeah, it can be very devastating.
Yeah.
I was just going to say, I have clients who are on this for dealing with like mental health challenges. I have one particular one who's in the, I guess, early 30s, maybe late 20s, and he was prescribed it when he was in the mental health ward at the hospital years ago, and he has the word, like every time he goes to a psychiatrist appointments, they want to reduce it because apparently the psychiatrist like association or the regulatory body, they're trying to reduce the amount of like doses and the
Right.
amount people are on. And he has really, really bad anxiety, and every time he goes off it's like a 0.5. But to him it's like the end of the world, and like
Right.
he says his withdrawal symptoms are like horrible for like 0.5. So then the psychiatrist at the next visit like increases it then, and like it's just like it's tough because once they're like, you know.
Yeah. So.
Kindling? What, kindling?
Yeah, I could talk about that in a sec. So I think that in many instances, people that are kind of hypersensitive to these dose reductions, you will find that it's more of a patient-driven approach that kind of goes beyond that of physicians and pharmacists. We haven't really been trained in this phenomena, but one of the things that patients are doing, particularly in the U.S., is a form of kind of dilution or tablet shaving. So trying to come off of their dose even at a lower amount than what is being prescribed. So what we do know about the benzodiazepines is that they come in dosage strengths, right? And even the lowest strength pill for many people is reportedly not enough to manage that dose reduction. So some people will literally use something like a food waste scale and a tablet shaver to kind of slowly shave off a portion of their tablet until they get a lower dose. Because the milligram content in those pills is intended to be hopefully equally distributed throughout that pill. But I think that is a rare and kind of last-ditch effort. The other option could be things like compounding pharmacies, but where they can make specialized dose reductions for people either in kind of usually like a liquid suspension form, but that often isn't either covered or always available for patients either. So
Do the psychiatrists give these options? Because
I don't think psychiatrists are often aware of them, and I also think it's a very much an emerging behavior or practice for patients to kind of come off of it. And this is where these self-support communities that have kind of formed around benzodiazepines and other drugs for that matter, including antidepressants, they're finding out their own strategies. And this is called, at least when we talk about antidepressants, hyperbolic dose reductions. So very, very, very tiny dose reductions, lower than you would get from
0.5 is still.
and it depends on the benzo, because some benzodiazepines 0.5 is not as much as 0.5 for another benzodiazepine. So some are far more potent than others. And there are equivalencies established between the benzodiazepines, but they're not highly evidence-based and firmly well established, at least nowhere near as well established as for opioids. So it does allow a lot of inter-individual variation, if that makes sense.
Yeah, no, it
Yeah.
does. And maybe that's
Yeah. And in terms of the kindling phenomena, that is maybe more the idea that just how you kind of kindle a fire by stoking it and trying to add bit by bit little pieces of kindling to generate the fire. When people are exposed to maybe benzodiazepines, even if it's not long-term use all at once, if they use a benzodiazepine for 2 weeks, wait maybe a number of months, use a benzodiazepine again for a couple weeks, wait a number of months, you might already be creating this phenomena in the brain where you're basically establishing a higher level of dependency potential, or like a benzodiazepine-induced injury in the future. Now, again, the evidence for this I don't think is firmly established, and it's more a term that is being kind of used around in more of the specialist circles for benzodiazepines, but you won't often hear within the core medical professions or psychiatrists talking about kindling and things.
I've only found one doctor in the city of Winnipeg, and I've been doing this for a long time,
Yeah.
that actually had that awareness
Mhm.
and knew those terminologies,
Mhm,
right?
mhm.
And actually understood what I was trying to overcome.
Yeah.
And talking about that type of tapering, they are starting to do some of that tapering in some of the groups I'm in now.
Yeah, that's
Where
good.
they're trying to, educate people on how to do sliver tapering or water tapering using, a very, very sensitive scale. And I know that, and I'm sorry, you're.
No,
the
no,
one
no,
that
no,
says
for-
I'm not.
no, by all means.
I'm talking from experience.
And that knowledge,
I'm doing it, right?
yeah,
And
that,
I'm helping other people. I'm helping lots of other people do this, right? So 20 years on, 20 months to get off, not always the case, right? I know a young lady, she's 30, she was on for 6 years. She tapered for 6 years, and now she's been off for 3 years, and she's still having, aphasia and dystonia and a lot of symptoms that are just related to the withdrawal and the recovery process, right? So it varies for everybody,
And it's scary, the withdrawal.
Depends.
It's almost like this guy told me, my client said, he's on the medication, it was prescribed to him at the mental health ward, he feels good on the medication, why change it,
yeah.
right?
Oh, absolutely.
And it's tough because he'll have withdrawal symptoms after, but the withdrawal symptoms aren't as bad, I'm assuming, as, the effects the drug is having on his body.
Certainly, and that's where, to your credit, the person with the best experience of themselves is the patient, right? So really trying to put them at the center of things and trusting their awareness of what's going on with their bodies is important. That being said, I do think that there is a lack of research and evidence on some of these newer phenomena that does need to be explored. And that's not to discount the real lived experiences of people that are struggling with these things. But this has been debated in psychiatry for decades when it comes to other issues, right? Other issues either being recognized as being a true disorder or entering into the DSM, or issues like psychosomatic symptoms and problems where we can't find a clear, well-established etiology or cause for what is going on. So it really, it's taking account of the patient and taking their lived experience very seriously, but then also trying to build the science around that, because in many cases it doesn't make sense. I also do encourage patients to try to be open-minded that fear of withdrawal itself, and like we know that drugs cause placebo effects. So when people are withdrawing, if they read a symptom list of 200 symptoms, what do you think is going to happen? They're going to start thinking, you know, I'm having withdrawal around every corner. So it's finding that balance so that people aren't getting too caught up in the potential of side effects or confusing other causes that are resulting in how they're feeling.
Yeah, and I've seen that in my groups, and I witnessed that talking to people too, and watching people talk, right? I mean, somebody will have different symptoms like myself or what, you know, and I notice that if I tell somebody else who's very vulnerable at that time, right? And has that high fear that, you know, there's a chemical, I call it a chemical fear when you come off the drug, right? Right away, they have that symptom as well, you know? And it's as severe for them as it is for me, right?
Sure.
They really develop it really bad. So, you know, trying to educate people around, you know, that fear factor to control your fear. You're not going to get everything, or you might be really severe, right? But in time, I'm glad people like you are coming forth to
Thank you.
listen to the person
Certainly.
and try to, you know, taper or modify or change the medication to that person's need. And I wish my doctor had done that, because I knew something was wrong.
Yeah.
Right? I absolutely knew something was wrong. And she wouldn't listen to me, right? She kept giving me other drugs, and then Zolpidem at the same time.
Yeah.
Oh my God. You know? But if she had listened to me, I might not have had to go through all of this.
Yeah, that's right.
I'm not blaming her. She probably didn't have the education.
And I think that most physicians and even most pharmacists would not have been able to catch that. I think that it's only been in the last probably 5 years in particular that some of these new kind of symptoms and even concepts such as bind or benzodiazepine induced neurological dysfunction are coming to the forefront. So until this is well established, people will still kind of be in the dark about it, including prescribers. So raising awareness is important, but also it's like anything, both considering the concepts and being open-minded and striking a balance, and also trying to really engage people with their tapering, and not being so afraid of all the drugs all the time either. So I still think that medication does have a very important role, but it needs to be a lot more modest than how we've been doling it out to people and spreading it around the way we have.
Oh, yeah, totally. Medication has its role in our world, for sure.
Yeah.
Like, I'm not against any type of medication, right? But it's really good that you're, you know, advocating to listen to the patient and not just assume.
No,
you know,
no.
it's something else, or we don't know what we're talking about, right?
Yeah, certainly.
So that's really important.
Well, thank you.
Yeah.
Any other questions before we wrap up? No? Okay.
Thank you very much.
Oh, you're most welcome.
Shake your hand.
Oh, thank you so much. Yeah, it was a
Thank
pleasure.
you. Thank you. And I'd like to thank everybody else for coming out today and listening to the talk. I found it very informative. It was really, really good. So thank you so much for that. And if you're thirsty or would like a treat or something, there's some stuff back there, so help yourself. But thanks for coming out.
Excellent.